Welcome back everyone to the channel Mediman, your guide to the clinical cases during your clinical years. Today, we are focusing on one of the most common PEDS emergencies, an acute asthma exacerbation in a child. This is something you'd encounter in emergency departments, general PEDS, and even in exams. Let's walk through a typical case step by step, and I'll explain not just what we do, but why we do it. So here's the scenario for today. Bradley, a poor 10-year-old boy, presents to A&E with increasing shortness of breath. He's been using his salbutamol inhaler hourly, but it hasn't helped. On arrival, he looks tired. His rest rate is 50. He's using his accessory muscles. He has widespread wheeze on auscultation, and his oxygen saturation is 90% on room air. What do you think are the red flags on Bradley's case? So first, let's talk about severity. Why does this matter? Because your management depends on whether the asthma attack is mild, moderate, severe, or life-threatening. Starting off with the mild, child can talk in sentences, O2 saturations are above 94% on room air, and there is a mild wheeze. Severe asthma exacerbation, saturations less than 92%, can only speak in words, rest rate above 30 to 40, use of accessory muscles. Then comes the life-threatening asthma exacerbation, a silent chest, exhaustion, confusion, drowsiness, or even bradycardia. Bradley with SATs at 90% and significant work of breathing clearly falls into the severe category. So, what do we do and how we help Bradley with severe asthma exacerbation? So, management is stepwise and every step has a reason behind it. So, we start off with the high flow oxygen to keep saturations above 94%. Hypoxia is the biggest immediate threat to life. Bronchodilators, we give them nebulized salbutamol, and in severe cases, we add ipratropium bromide. These relax airway smooth muscles and reduce bronchoconstriction, which would help Bradley to breathe with ease. Oral prednisolone or IV hydrocortisone steroids don't work instantly, but they reduce air inflammation and prevent relapse over the next 12 to 24 hours. If the child isn't responding, this acts as a smooth muscle relaxant and can be life-saving in severe attacks. So we give them IV magnesium sulfate to help with that. Early escalation is important. If the child is deteriorating, involve the PICO team or the PEDS intensive care team early. Waiting too long is dangerous and childs are fragile. While all this is happening, monitoring is crucial. Continuous SATs monitoring, regular OBS, and checking perfusion. Why? Because asthma attacks can go either way very quickly. They may improve dramatically or crash into respiratory failure. What do you know about the signs of rest failure? Comment in the comment section and let us know what you think. Once you've treated the child and the child is stabilized, that's not over yet. Discharge planning in asthmatic patients is quite important. So how we do it? Let's just go through it step by step. Check how the patient uses the inhaler. Many children relapse because they aren't using the inhalers correctly. So make sure you teach them and educate them about how to use it correctly. Give them a written asthma action plan so parents know what to do when symptoms flare. Review preventive therapy. Does he need an increase in his steroid dose or a change in regimen? Arrange a follow-up with GP or PEDS rest team within 48 hours. That's important. Educate the family on red flags if reliever is needed more than every 3 to 4 hours, if the child is getting drowsy, or if they are persistent hypoxic. They must come back to the hospital. Safety netting is the key. Make sure that you educate the parents, and if the child is of understanding age, educate them as well. Let's just quickly go through what we have spoken today about asthma exacerbation in a child. So step one, we recognize the severity if it's mild, moderate, severe, or life-threatening. Step two, We start off with oxygen, keeping the sats above 94%. We provide them with bronchodilators, steroids to avoid relapses, and escalate with the picotaine if needed. Step 3. Plan a safe discharge with education and follow-up. Asthma is common, but with systematic management, outcomes can be excellent. If you found this breakdown useful, don't forget to like, share, and subscribe. In the next video, we'll cover another common PEDS emergency, bronchiolitis. See you then. Bye bye until then.